Yeah.
Excellent. Well, it's almost as if we've got a proper webinar here. So there we go. So welcome back to everybody who is who's come to watch this. I'm just checking that we're actually recording. I think we are. And we have another international panel. This is the fourth BAPO webinar. This one about airways. The first special guest all the way from Brisbane in Queensland, Australia is Hannah, who's got out of bed specially early to be with us. And that's why it's kicking off at 9 o'clock tonight rather than the usual 7 o'clock. Hannah was a fellow at the Evelina in London and is now a professor. Are you professor? Is that right?
I think you've just elevated my academic status, but
senior lecturer.
You're senior lecturer, yeah, that's right.
No, something on the internet said you're a professor. No, well, that's good enough. Okay. Guest number 2, Ravi from Sheffield, who's been lead paediatric NT at Sheffield for some time. He's also very into teaching, has a lot of fingers, a lot of pies, and he's one of the co-secretaries of BAPO. The other co-secretary of BAPO is Stephen Powell, who's a paediatric NT surgeon up in Newcastle. He has a big interest in airway intervention. He's chair with a nice airway intervention register. He's the other co-secretary of BAPO. Funny what you find on the net, Steve. I'm just wondering what's going on in that particular picture. That looks like me in lockdown with my hair.
It was true love. True love. So the arm you can see on the right of the picture is looking at is actually my wife.
Okay.
But you can see where my attentions are diverted.
Yeah, well, I'd be impressed too. And the fourth member of the panel is my colleague in Bristol, Julian Gaskin, who's one of our newer consultants. Julian was a fellow in Manchester and trained in the East Midlands. And he and I basically do exactly the same job and try to dump as much work on each other as we can. Lastly, I'm chairing it. The only thing I've got of interest to say about me is that I'm the only person on the panel who qualified and trained entirely in the last century, which may explain some of my answers this evening. Okay, so if anybody would like to ask a question, don't put your hand up, don't try and unmute yourself because I don't think you can. There is a chat function which I will try and monitor during the evening, and you can try and send a chat message. I'll try and answer if I can. Okay, intubation trauma is the subject of this evening's talk. Now, my great mentor when I was on my fellowship in Sydney was Bruce Benjamin, who is the person that the laryngoscopes are all named after. There's nothing he loved more than taking photos of larynx. He was affectionately known as the professor of laryngeal photography by the anaesthetists because he used to take so long over an MLB. But I was so happy when I found out that he was in charge of my fellowship because I like taking pictures as well. Sadly passed away a couple of years ago. If you ask, or if you use the word Benjamin laryngoscope, it's a bit vague and woolly because there are about 10 Benjamin laryngoscopes, and there are all sorts of other bits of kit with his name on too. The two you will probably know are the Benjamin Lindholm and the Benjamin Parsons. There's a slimline, a subglottoscope, there's all sorts of Benjamin scopes. Right, so I'm going to do a quick preamble about intubation trauma. It comes as a result of pressure from the endotracheal tube, and if it's pressing too hard, you get reduced capillary perfusion in the mucosa. You then get ischemia, you then get swelling and edema, eventually you get mucosal ulceration, and after a while that'll break down to underlying perichondritis in the cartilage below it, and then cartilage necrosis. So that's how it happens. And then as it attempts to heal itself up, it can heal either by forming granulation, and this is actually an adult larynx, but these are the classic tongues of granulation that you get over the vocal process of the arytenoid, and a lovely sloughy ulcer at the posterior commissure there from pressure necrosis. And the other thing that it will do as it heals up is cause fibrous tissue and scarring and scar formation. So this is a fairly classic posterior glottic web as a result of scarring. Now, in the adult, the glottis is the narrowest part of the airway, and these are the bits that tend to get pressed on. In a child, classically, the subglottis is the smallest bit, so we tend to get more subglottic stenosis, and that's a fairly textbook picture of a nice subglottic stenosis. But of course, children get both sorts. They're mixed. They can be glottic, subglottic, or both. They can be hard, soft, inflammatory. So that it's quite a wide field. The other thing that we were discussing just before we came on air is subglottic cysts, which appear to be particularly common in Manchester for some reason, but they are an increasingly common function of intubation trauma in neonates particularly. And it's as a result, I presume, of the endotracheal tube blocking up one of the glands in the mucosa and it forming a cyst. But they form beautiful pictures and nice bit of airway obstruction too. So moving on, if I can, just going to fiddle around with the controls again for a minute. Back to PowerPoint slideshow. Right, so extubation failure, let's define it. We've got an intubated child. The child gets an intubation injury, which leads to one or more of the following: edema, granulation, and scarring in the glottis and subglottis. And as a result, when they pull the tube out, the airway is obstructed and the child can't breathe, has stridor, they have to re-intubate it. It's a fairly common scenario for most people working in children's hospitals. But of course, it is also a problem in DGHs. Anywhere that has a neonatal unit with small babies on it, it is potentially a problem for you. So, in a nutshell, what can you do with it? Number one, re-intubate it, send it to somebody else, which is the runaway option, which is actually, I'm not being funny, it's a perfectly reasonable option. If you work in a small unit, you re-intubate them and get them transferred, intubated to your local centre of excellence. Unfortunately, for us on the panel, re-intubating and running away isn't the option because we're supposed to be the centre of excellence. So all the options available to us are a bit of medical treatment and then try again a few days later. Do something endoscopic, and we'll come on to those later on. That could be all sorts of things. Do something open, and we'll come on to that later. Or just go for tracheostomy, which is, of course, the definite final solution to extubation failure, but it's quite a big step that we try to avoid if we can. Good. Now we seem to have absolutely no more slides, which is a bit of a shock. Just bear with me, panel.
I'll just mention while Hannah's doing that
Yeah.
classical appearance of the heaped up edema around the endotracheal tube. Peter Bull, my mentor, used to call those the seal flippers because he figured they look a lot like seal flippers, and he put it in his textbook. But that's a really classical appearance, and if you see that, and that appearance I've seen that after 48 hours of intubation, and if you've got that appearance when you take the tube out, then yeah.
What do you do with those, Ravi? Do you always take them off? Do you never take them off? What do you take?
Well, I think we're gonna get into this in a bit, but you kind of eyeball this, and you know, sometimes they're kind of pedicled, and you feel as if you're just going to grab it and something's going to come away in your hands, and it's going to be great. And other times you get this more diffuse kind of edema, and you feel like, you know, you're just not getting anywhere with anything you do to it. Anything you do makes it a bit worse. So it's kind of a judgment call on those. Yeah, you kind of have to imagine. I think what I do in my mind's eye is I kind of imagine what the maneuver I'm going to do is likely to achieve, and then think to myself, is that going to improve the appearance of the airway?
So I've got a couple of cases that we've seen in the last month, which aren't technically failed extubation. They might more technically be failed ventilation, but for whatever reason they thought ENT might be useful. So I suppose these are just kind of interesting little cases that be interesting to see what everyone else thought about this. I'm sure everyone at a tertiary hospital has come across this, you know, these calls from intensive care, NICUs and PICUs, where you go, really, I'm not quite sure if that's really our problem, but for some reason they think ENT can fix everything, and maybe we can. So this was the first little one that we had about 6 weeks ago, a term baby born elsewhere, small baby, only 1.8 kilos, poor ATGARs at birth, needed resuscitation. Apparently a difficult intubation, but someone got a size 3 tube in. They were then transferred to a NICU, which wasn't in our centre. And within the day, someone had decided they had pulmonary hypertension, and the cardiac surgeons got involved. And in order to get that child to our PICU for our cardiothoracic team to look after them, they were put onto VV ECMO. So some very big catheters put into this tiny baby's chest and transferred to our PICU. Now, I don't know much about pulmonary hypertension, but apparently it can get better. You put them on ECMO for a while and it gets better, and you can extubate them. That's what our cardiothoracic team thought anyway. The child was mildly dysmorphic, but normal genetics. Very challenging family situation. In fact, I still haven't met this family's parents at all. And the child was on ongoing ECMO, but they were also ventilating via this 3-tube orally as well. And over the days till we got to know them, the tube had been changed a number of times, and no one had reported that the tube change was problematic at all. Day 5, we were asked to review because they couldn't suction down the tube and they weren't ventilating the right lobe very well, and there was collapse on that side. I was stuck in clinic, and it was going to be a couple of hours till I could kind of get up to clinic, and there was obviously nothing urgent there. So I thought a scan would be a reasonable idea. I don't know what everyone else would have done, but I thought send the baby to the CT scan. It doesn't really sound like a hugely ENT issue. And off it went. And I'm not sure how well people can see that, but anyone want to comment on anything they can see there? Throw it out there. Got a tube that's a long way down. They did push it down quite well. But at the bottom end of the tube, it gets kind of narrow. In fact, on the axial, that was kind of like 2 mils at best at the end of the tube. So on the image on the right-hand side. And suspicious of complete tracheal rings. What would anyone else? What would you guys done next?
Hannah, can I just ask you, why were they changing the tube so much?
Good question. Good question. I think because they weren't ventilating that well, so everyone thought, oh, we'll just change the tube again. It must be something to do with the tube.
Okay.
Yeah. Good question. There was a lot of unanswered questions about this baby, and even the fact it ended up on ECMO because it didn't really qualify at its size for ECMO. So
it sounds like the tube is right at the tracheal stenosis, and it's probably caused some edema and swelling that's led to further narrowing. So obviously the complete tracheal ring will need to be dealt with at some point, but you may be able to get some steroid in there to reduce some of that swelling. It's difficult to know what's fixed and what's soft.
Yeah. So we definitely thought we should go and have a little look. The baby was an ECMO, so it was pretty easy to take this baby to theatre and do an airway examination. Don't have to worry about ventilation when they're on ECMO. And I think I can show this video. There's nothing particularly subtle about this. So
traumatized.
I know, counting rings. I think I counted about 6 rings there that they'd managed to rupture.
Hannah, it's nice to start with the easy cases, isn't it?
Yeah, absolutely fabulous. Yeah, I thought I'd just jump in with these.
Right. Okay.
And this is a 1.8 scope. So there were complete rings at the bottom of the stenosis. You could get through with a 1.8 scope. And then there was normal trachea, probably for the distal third, for about 1.5 centimetres below that.
Wow.
And interestingly, no sub-Q emphysema on the scan or clinically?
No, never had subcutaneous emphysema. Maybe because the tube was so tight, ran down there. Maybe because they weren't ventilating strongly because they were also on ECMO. I'd be interested in what would you guys have done then? I kind of looked at that and went, ooh, that's...
Oh, well, I'll start. I think I would call the thoracic surgeons.
They were standing over my shoulder. They were standing over my shoulder going, interesting.
Well, I suppose, I haven't dealt with a lot of these, to be honest. I'd probably, the options are to open the chest, I suppose, and try and repair it from the outside, or if it's ventilating and stable, see if it walls off on its own. I mean, we don't do a lot of lower tracheal stuff, so I'd probably be on the phone to Richard Hewitt at Great Ormond Street. I don't know what anybody else would think. Ravi?
Sound, Ravi?
Muted, Ravi?
Yeah, sorry. It really depends on how that left lung is doing and how, if I think you could get away with a tube. You could have got in there and maybe given it a bit of a clean out and a wash out, and then put a tube into this gap, and then kept them on ECMO, and then just if the lung starts to reinflate, then I think you've got a good chance that you might get away with it. But I certainly would run it past my cardiothoracic buddies, to see what they thought.
We don't really do slides in our centre. They all get sent down south. So, a lot of this was very theoretical. They were kind of interested, but we decided we'd see if this hadn't caused any problems. So we thought I couldn't get a 2.5 tubes through the stenosis at this stage. So I sat a 3 tube sitting at the stenosis with the bevel over the top of that tear. And we were able to ventilate both lobes if you sat the tube in the right position. So we'll just sit with that for a few days. And then went back the next week and had a look, and it was starting to heal up, and we then could squeeze a 2.5 through the stenosis. So opted to put a 2.5 tube through the stenosis so they could ventilate both sides a little more stably. And that's kind of where we're sitting. We've managed to get the child off ECMO, but we can't get it off the oscillator. And bottom line is this kid's got crappy lungs, and probably will go palliative in the end of the day anyway. But I suppose a bit of a cautionary tale for pushing tubes too hard.
Wow.
To all our colleagues, but I've certainly never seen that happen before.
No.
I mean,
And it's interesting, isn't it?
That they were on ECMO, because if they weren't, then they would have really struggled with their ventilation.
You would have thought so, yeah. Interesting, we found one paper from Korea of a patient who was treated with complete tracheal rings, long tracheal rings. The family refused an open approach, and the Korean team endoscopically divided the balloons segment by segment with a balloon over a period of a couple of weeks, and managed to split them all, and the child survived. So one of our thoughts was we could try to split those last couple of rings with a balloon endoscopically and see how we went. But I don't think we're going to get there, because I think the child's going to be palliated.
Does it have a lot of other morbidity as well?
It looks minorly dysmorphic, and the pulmonary hypertension. I think the pulmonary hypertension is really a major big problem, and the lung is not ventilating very well at all. So the child probably should never have got on ECMO in the first place, and this probably should have been palliated from a very early age, but very early time. But funny things end up in your department sometimes.
Yeah.
Do you know if the child arrested at any point? Because typically rings are meant to do that, aren't they? If you start doing stuff to them, they can be pretty dramatic crashes, and they managed to transect these rings. It's sort of remarkable that they sort of almost got away with it to some extent.
I suspect because they were on ECMO.
Yeah, probably. Great. Hannah, have you got another one you wanted to talk about, or is that enough?
I've got one other little one, and then...
Yeah, go on.
Okay. So the second one was a 30-week prem, born elsewhere also, intubated with a 2.5 tube elsewhere, and they weren't ventilating very well. And so we got a phone call over the phone saying, oh, what can we do? We can't ventilate this baby. And we're like, well, that's really not our problem either. You've got a tube in. I'm not quite sure what we have to offer, but why don't you scan the baby and see if there's anything funny in the lungs? And once again, this is a spot diagnosis. There was something funny in the lungs.
Can't work that out at all.
So we've got tube, we've got collapsed lung, we've got a bit of consultation. There's something foreign. I don't know.
Well, the thing that's horizontal, you mean?
Yeah, the thing that's horizontal. Have anyone got any ideas what foreign body could be in this child's
Christmas
lungs?
BMJ, this one. I can't work this out at all. Yeah.
The only thing this child has been done was intubated. So
someone suggested it might be a bougie.
Yeah. So the child had to be transferred to our centre, and anyone who's done a scope on a 30-week prem knows that you can't get an optical grasper down the airway well. There's very little you can do. Went into suspension. The child actually was able to be managed oxygenation-wise and high flow. Little 1.8 scope down the lungs and down the trachea, and a little optical grasper because 6 centimetre piece of the bougie, so the plastic off the bougie.
So did they notice that it was missing at the time that they?
No, no.
Silly question, yeah.
And we thought, oh, we'll write this up. This is unusual,
Yeah.
but unfortunately, there's quite a few papers in the literature over the years of exactly this.
Okay.
The little smaller stylet, the plastic can come off if you push too hard.
Yeah.
So just...
Fantastic. That's really good. Thank you very much. So if you could stop screen sharing, what I'm going to try and do is do the presentation from my desktop, which I've logged into as well, which share the same microphone. So can you end screen share?
Yeah, I'm just trying to do that.
That's great. Julian, you want to come and sit over there slightly? Right. So can you still hear me, Ravi, Steve, and everybody?
Yep.
Yeah.
Great, that's good. So I'm going to go for share screen now, and I'm going to go for PowerPoint slideshow. So have you got a slide from me?
Yes.
Fantastic. Right. So we're now using two separate computers in the same room with one microphone and one camera. Julian's going to remain on camera. I'm going to be around the corner. So I'd like to start by asking Steve, let's say you've been asked to go to NICU and they say we've got a 30-week pram that's failed extubation twice and we'd like you to come and sort it out. What would you go to the ward and do anything? Is there anything much you'd do?
I do like to go and actually have a good talk to the neonatologist or the intensivist. I think it's really important to kind of get a grip on what's happening with the child overall, I think. Because there's lots of reasons these kids fail ventilation, and sometimes it's a little bit speculative about whether it's the airway or whether it's the chest. And I think it's really helpful. We've got one on the go at the moment, an X27 weeker who's going to go to theatre, just keep failing, but we don't really know one of these mixed failure pictures. So we do get a lot of mileage out of actually going and sitting down with the neonatologist going through it. So I think it is worth it, and actually sort of gearing yourself up for what you might find, and likelihood of success given the chest and the other things, I think.
Yeah. Ravi, any other thoughts? I mean, my experience is these kids have been pretty well worked up already. They've had chest x-rays and all the bloods, and they've usually had an echo and so on.
Yeah, no, but I would just echo what Mike said. I think that trying to get a handle on what's actually happened, I do feel that it should be I use this term, it's a bit derogatory, but I think it should be the grown-ups who talk about what's happened to this kid up to that point. Often with the older kids, on a strong history, I won't really see them. I'll say yes, book them for theatre. But these little tiny babies, taking them to theatre, it's quite a big step. There's a lot that can go wrong with them, and so it's really about senior people talking about what has actually happened up to that point, because things really get lost in translation, how they actually failed. If they were a difficult intubation, were they really a difficult intubation, or was it relatively junior people doing that intubation? Was there a lot of trauma that happened during that intubation? All the other stuff, of course, which I presume we're going to talk about, like what's their oxygen requirement, what tube have they got in, are they leaking around the tube? Those things, of course, play a big role in our understanding of, as Stephen says, what are we hoping to achieve? The question they're asking us is, do we scope them? And the question is, what can we achieve with that?
They don't. Yes, I think they don't always. They don't always present here whether
airway lesion. Yeah. I was going to say, Hannah, say you've decided that you've agreed with the neonatologist or the intensivist that you're going to take a child to theatre who's intubated and has failed extubation twice. Once you have the child in theatre, let's say they've got an endotracheal tube down, what do you do next exactly? What instruments do you use? What's your technique?
With a good anaesthetist as well, because you have to, these kids often aren't easy to ventilate, aren't they? So you want kind of a good team. I tend to use the Lindholm laryngoscope in suspension with the Benjamin Harris light source on it, and I tend to leave the tube in while I set up. So set up with the tube in situ, and have a look around that tube first of all, with a decision of how we're going to ventilate this child when we pull the tube out. And in our centre, that would often be with high flow, but with a rescue tube available as well. Making sure the child's spontaneously breathing. Sometimes they're not, and it takes a while to get the child breathing again when you get to the theatre. with some adrenaline available. So once they're spontaneously breathing, the anesthetist really happy with them, and you're in suspension with a good view of the larynx, pull out the tube and assess what you've got. And making sure you're assessing both structurally for problems, but also for functional, see if we can get cord movement on both sides, dynamic assessment of the lower airways if possible, and assessing what the abnormality, structural or functional, potentially is. A lot of these babies have had PDA repairs, so it's not unusual to find a vocal cord palsy, which may just be the thing pushing them over the edge. And even laryngomalacia occasionally as well. Sometimes it's harder to assess in these little ones if you can't get a good functional view.
I must say, my experience is I find that they're often so full of clonidine and other things that it's very difficult to get a good look at their vocal cord movement, because they're a bit brittle and the anaesthetist can't get them quite into the right place. I don't know. Anybody use flexible endoscopy in this scenario? Not particularly. I think.
Yeah, we do actually. We tend to, like most of them, would get flexible at the same time if we think we're going to get a dynamic use. I think it does change things in terms of the dynamic things. So once you get them on suspension, there's certain things that you maybe won't appreciate the significance of as much. So we always try and do flexible at the same time and then suspend.
Okay. And you have that going through a face mask, do you, with the anaesthetist just doing a bit of jaw thrust?
Yeah. So. Yeah. Ideally, so if we can get to that stage, we'd probably take the tube out with a Hawkins rod under direct vision in case there are any granulations that we're about to slip into the airway. So we can zero down on that. But if there's no apparent immediate obstruction, probably then at that stage, once the tube's out, go to a flexi and then address with a suspension any abnormalities. Okay,
let's move on to another slide then. So this is a very straightforward one. I'll just go back to Ravi, 10-year-old child who is struggling with airway and saturations and has very quiet inspiratory stridor, but it's not very clear-cut, slightly dysmorphic. There has been a suspicion that there's unilateral choanal atresia because people are struggling to get a nasogastric tube through one side. But in fact, you find that when you look in the nose, it's just quite marked neonatal rhinitis, which of course might explain quite a lot of the problems the child's having with its airway. And these are the findings when you look at the larynx. So there's this is mild intubation trauma. Let's say the cords are mobile. I can't tell you that because it's not on this picture, but there's just edema all over the place here. Would you do anything about that, Ravi?
Sorry, I didn't quite get the history of how this child ended up on your operating table. Had they been intubated at birth? Or?
Okay, sorry, it's a slightly vague history. The child is dysmorphic, a little bit complex. It's desaturating quite regularly. It has been noted to have stridor from time to time and some recession. So there appears to be airway obstruction. But the picture isn't clear-cut absolute stridor. There's some stridor. There's a query of a unilateral choanal atresia, although I didn't go up there myself and stick a scope in.
But the child had been intubated at some point. I missed that.
Yes, I'm sorry. It had been intubated in the first couple of days. I'm so sorry. I didn't mention that. Yeah.
Okay, fine. So intubated first couple of days because of airway problems at birth.
Yes, exactly. And it's been extubated. It's kind of just been not quite right since.
Fine. Okay. And so,
I mean, looking at the larynx there, if you ignore everything else, what do you think of that larynx?
Yeah, just run the video again. I was still trying to figure out why he had intubation trauma, but
yeah. Pardon me. There are no tricks here, Ravi. I keep saying that. I mean, do you think that's even significant?
Sorry, say that again.
Do you think that's even significant as intubation trauma goes?
No, that's pretty good actually, all things considered. So no, I think that's not really his main problem. It might be a contributory factor, but you'll know that based on whether he's getting better or worse. I mean, if he was intubated and extubated at day 2 and he is continuing to improve day by day, then you can put that down to resolving post-intubation edema. If he's getting worse, over his 8 days of unintubated life, then it seems likely that that's the main driver of why he's got a problem now.
Yeah, and in fact, I would, I don't think anybody else in the panel disagrees. That's mild intubation trauma, and in fact, he got a lot better when we stuck a nasopharyngeal prong in and sent him back extubated, and that was clearly that was the main point of that slide. So let's move on to the same child a few months later. So there we are. He comes back. He's now got more impressive stridor 6 months later. And of course, his larynx is now pristine. So you can see that sort of level of intubation trauma just resolves on its own. But what he did have at this point was a bilateral vocal cord palsy, which I hadn't been able to assess the first time, which goes back to that thing that I think Hannah or someone was saying about cord movement. And it can be a little bit tricky to see. Right, another one here. Failed extubation on the neonatal unit again. I'm not giving you a lot of history, I'm sorry. Steve, without knowing much of the background, let's say it's a failed extubation, but there's a few pulmonary problems. Do you think that larynx itself is enough to account for failed extubation?
Well, probably not immediately, but depends on when they fail. So I think the things that we can say, so there was good cord movement. There was a bit of posterior, you can see a bit of posterior on the cricoid when you probably run the video again. Yeah. Obviously quite a bit of tracheobronchomalacia going on.
Yeah.
Trying to figure out whether that's a primary or secondary problem. So we've got cord movements, that's a positive. And then you can just see posteriorly on the cricoid, yeah, sort of laterally on both sides. So there's definitely been a bit of tube trauma there.
Yeah, exactly
and,
right.
And everything's a little bit floppy. So
that's why I put this particular video in, because you can see those sort of ulcerated troughs on either side where the ET tube has been. Now, again, I think that probably isn't his main problem. I think the main problem in that kid's in this child was the lower airway and the lungs as well. That's just really a feature. So another thing that's I've got to be in my bonnet about cuffed ET tubes at the moment. This is another one that had had problems after prolonged intubation with cuffed ET tube, and it seems to be an increasing fashion on our ITU to use cuffed ET tubes, although they did originally go out of fashion in the 1980s because they caused so much trouble. And this particular one, you can see that there's granulation there. You can see a sort of bridge of edema there, and then a gap where the cuff's been sitting, and then another ridge below. You can see where that cuff has been sitting, and that cuff has been too high and the pressure hasn't been monitored enough. Do you, in your units, any of you have problems with cuff tubes, or is it exclusive to Bristol? Ravi?
Yeah, so it looked a few years ago like cuff tubes were going to be a thing, but they never really took off at Sheffield. I mean, intensivists like them typically in the slightly older children, but by and large, we don't really use them very much definitely don't use them in the neonates. We definitely don't use them in the younger children. Obviously, the older children, 2, 3 and above, PICUs tend to like them.
Yeah. Steve, do you have any experience of cuff tubes in small children?
Yeah, so that was because the cardiac units, there's quite a lot of kids who are fairly clapped out, so needing high pressures, ventilation, LTB, all that sort of thing.
Yeah.
So we do see it, but I think the intensivists are onto it sort of pretty well, so that we're not actually seeing a whole lot of cuff trauma. We had one tracheal stenosis from cardio in the last couple of years, but that was it. And they tend to have the cuff position right, so it tends to be a tracheal issue, if anything, I think.
Yeah. Hannah, do they use cuff tubes in Brisbane?
Not in the NICU very often, not at all. PICU, similarly cardiac-wise, and the kind of long-term ventilation bubs with really bad low airways and needing to ventilate potentially, but we haven't really seen a whole lot of problems, I'm glad to say, with them. But I agree, they can sit in the wrong place, and often the cuff seems to sit just below the vocal cords rather than further down.
Rather than below the cricoid, yeah.
Yeah, they seem to sit a bit high, don't they? They pull the tube up a bit high, and the cuff's just sitting just below the vocal cords.
I mean, Julian, it's my impression we had a run of these about 3 years ago, didn't we?
Probably not even as long as that, but we had a run where they would just seem to be cuff trauma after cuff trauma, and I don't think they use a lot of cuffs. I just think we had a run of them, and the problem they had was just problem that we perceived was that they just weren't using the manometers regularly enough. So they were just, whacking in as much pressure as they needed to prevent a leak, but not necessarily really focusing on what the cuff pressure was. And I think that was our concern, was that these cuffs were such high pressure that they were definitely going to be causing trauma to the trachea.
Yeah, but it did seem to be something that was a few years ago, and my impression is that they've learned the lesson and they found the manometers that were in the cupboard for 10 years, and now they're using them properly. Okay, now here is another one with a bit more history. This is a case of Julian's. Hannah, I'll ask you about this one if that's okay. 25-week ex-prem, had been ventilated for 4 weeks, let's say, and was transferred from one of our outlying units with biphasic stridor. It was very obstructed, seen by Julian, and he decided to take the child to theatre straight away. And this is the diagnostic MLB. Sorry, it's a bit fuzzy. Can you see that okay?
Yeah, it's all good.
A little bit soft focus, as everything in Bristol is.
Am I seeing some cysts? Oh, fabulous subglottic cysts.
Yeah.
Excellent.
Aren't they?
Excellent. They're fabulous. Big grapes. This always makes you feel good, doesn't it? Because you're going to be able to fix this fairly quickly, or at least short-term fix them.
That's coming. Yeah. So what would you do there?
Yeah, so I tend to use cold steel for this in suspension, grasp them with a little pair of graspers and a little sharp pair of scissors and de-roof them. And I know some of my colleagues use microdebrider, but I just tend to find the scissors and sharp dissection is the quickest, easiest thing to do to de-roof them. Yeah. And then good look, because there's generally a degree of subglottic stenosis associated with them, whether that's acquired or whether it's congenital and they've just had a too small tube down there. They're usually better straight afterwards, but I've got a very low threshold to bring them back and have another look within weeks, because sometimes they reoccur or another one pops up, and it's also easier to reassess that subglottis at a later date. In my experience, generally they do very well as soon as you pop them, and symptoms are a lot better fairly quickly.
Yeah, Ravi, what do you use to deal with these?
Yeah, so I prefer cold steel for them. You sort of pop them and try and remove a bit of the loose mucosa and then see how it looks. You can sometimes balloon them. I have had cases actually where even after I've done them, there's still not a great airway left at the end of that. And so I've split a couple of babies endoscopically, because I felt like I even after taking the cyst, I wasn't too keen on the airway. But I agree with Hannah. I think they almost inevitably you get a bit of comeback from them, recurrence, and so yeah, I tend to scope them. I don't tend to do it within a week. I think usually if I've got a good result, I'll leave it about 4 weeks, something like that. But I think it is really worthwhile scheduling them in for a cold scope.
Agree with all of that. Steve, cold steel, laser, coblation.
Oh yeah, all of that. No. No, just cold steel. I think Hannah's and Ravi have got it spot on. I don't think you need a powered instrument. The cysts come away beautifully, and you want to preserve as much mucosa that is good as possible. So I think that's the way forward.
Yeah. Well, so Julian likes to use cold steel as well. And here is the immediate post-operative result of it being very gently de-roofed. And you can see you've got a lovely airway there with maybe a tiny little bit of soft stenosis, but not much else. And then at follow-up MLB 3 months later, I think we probably would have gone sooner than 3 months. It's just we have a big pile of work, which has only just got bigger. So there's a little bit of a recurrence, but I think probably not enough to. I
snipped those as well.
Oh, you did?
Yeah, just because I just thought I should.
Hard to resist.
Yeah.
Masterful though, masterful appearance.
Well, it went so well the first time, didn't it? Okay.
But that was it. Once after the second one, it was done and dusted. I haven't done anything. I haven't looked down since, and he's asymptomatic.
Okay, good. Personally, if I have time, I'll come into it. I like the microdebrider for those cases because I just like to get a little bit of the roof of the system bited off, and I like the fact that you're only putting one instrument down between the cords, but it's very much personal preference. Does anybody worry about doing them on on both sides at the same time, in case you get a synechia across the middle. Has anybody? I've heard people talk about it, never seen it. No, clearly not. Okay, we'll move on. Okay, here's a newborn baby that was a fairly recent one of ours. Severe stridor from birth and unilateral cerebellar hyperplasia noted on the antenatal scan, otherwise a normal looking baby. And to me that sounds like a vocal cord palsy because of the immediate severe stridor straight from birth rather than laryngovulation, which comes on more slowly. For various reasons, technically, we couldn't get a good view of the cords on the neonatal unit, but I was almost certain it had got a bilateral cord palsy. Arranged an MLB within a few days, but over the weekend in between it had to get intubated because the airway just went off really badly. And it didn't help that both of the parents were actually medics. So here is some intubation trauma. You can see a big ulcer there on the anterior wall where the tube tip's been. You can see that there's sort of diffuse edema of the cords. There you are. That looks like a bit of intubation trauma. I won't ask Julian because he knows this one. Ravi, would you? I mean, when we looked at the mobility of the cords, it was clearly a bilateral cord palsy. Do you think that intubation trauma is adding anything, or it's just an incidental finding?
Yeah, I don't think it's huge. I mean, there's obviously some trauma anteriorly, but with the view that I got, I don't know that that's the main story.
Not a great view, no. Well, I wasn't completely sure because at various stages in the baby's short existence, it had been absolutely fine, and I wondered whether the intubation trauma was the thing that had tipped it over the edge, because some babies with bilateral cord palsy can get away with it. So we gave it a big dose of steroids for a few days, and it did get better, and then it went off again, and eventually kept going off. So we wound up with a tracheostomy. So that's just an incidental finding. So let's move on to another one. 3-month-old ex-prem, again a failed extubation. Actually, let's skip that one because we're actually. Is this your one, Julian?
That was a lot of granulation.
Right, let's watch this one. I'll let Julian talk you through this one.
This is the typical scenario that we said about NICU patients, failed extubations. So you bring them to theatre, pull the tube, and that's what I found. So I thought that would, well, I suppose we can ask the panel, what would you do at this point? You've just literally taken the tube out in theatre. What are you going to do?
The distal airway was fine, by the way. We're not showing you the distal airway. This was purely glottic granulation and edema.
Hannah, what would you do?
I love a balloon. So I think you're going to need to get that airway a little bit better fairly quickly, because your anaesthetist is going to start struggling soon and your ventilation is going to be poor. So I'd be fairly quick to put a balloon down, balloon all that out of the way, make the airway at least temporarily better, and remove any granulation tissue. Probably put some steroid down, inject some steroid, perhaps put a bit of steroid, put a tube back down again, a smaller size tube surrounded in steroid, and give it a bit of laryngeal rest, and come back and look in a few days or a week's time.
What topical agent do you use, Hannah? When you say surrounded steroid, what topical?
Kenacone. Kenacone, and I'd potentially also inject Kenacort if I could get that in there. Sometimes that's a bit hard in these little ones to get it anywhere. But a big blob of Kenacone around the tube, top of the tube, is sometimes helpful. I don't think it hurts.
Yeah, I agree. We both learned that from Mike Rotherham in Manchester. And you could just think of it as an alternative to using Aquagel on the tube. It's not going to do any damage, and it might do a bit of good. Do you, Ravi, Steve, do you do that? Either of you? Steve? Yeah. Ravi, do you use? There's no evidence, say it one way or another, but it's not going to do a great deal of damage. Okay, Julian, would you like to tell us what you actually did here?
Oh, I just snipped it out with scissors, actually. Just a bit like the subglottic cysts. I just thought it was amenable to snip out, so I just snipped them out. A little bit bloody initially, but
I'll move that.
Yeah, also I was keen to get there. The trouble I find with the neonates is that they can desat really quickly. Obviously, they come up very quickly as well. And I suppose my concern with putting a balloon in is that you've already got a really poor airway, and then you're gonna block it for a little bit longer with a balloon. So I wasn't sure how long I would actually have to deploy the balloon for. So I thought even if I snip one side out, then I've improved the airway by say 20-30%, and that might just give us a little bit more time. And I think I was just sort of intubating and extubating during this as well, because she would desat it on occasion. So it took a little bit of time, but I just ended up chopping them out, to be honest.
And I think that's the end result.
That's the end
result. So certainly, I don't surgically remove granulations very much, but certainly, occasionally you have those big, what people call seal flaps on either vocal process where they really are obstructing. I'd certainly very carefully shave those out with the microdebrider. Hannah, would you do the same thing? Do you ever remove granulations?
Oh, absolutely. If it's there, I'll remove it. Cold steel, microdebrider, whatever kind of works on the day. Whatever's easy and close to hand. Sometimes it takes forever to get the microdebrider set up, and it's just too slow, isn't it? And so
this is me actually putting a little bit of steroid ointment over the tube and then putting it in, just like you described, Hannah.
Yeah, just like you described. So I must say, but there you go, tube covered with steroid cream. So we've covered that slide already. We don't get Kenacomb. It's what we used to call triaccortal in the UK, but it's difficult to get hold of. We use what do we use?
Anything, Cinelar.
Yeah, Cinelar, hydrocortisone, any steroid cream we can find in the anaesthetic room.
I have to say though, do you mind if I just say, I'm with Hannah with this. I think that getting a balloon in really quickly, that view that you had right at the start, it's hard to tell what's what in that picture. I suspect the real world view might have been a bit better, but I really find that if you can get a balloon in, even if for 30 seconds, it just tells you where the main problem is a bit better, I think. And you've just got a bit more time and a bit more leeway. Obviously, it's a bit hairy when that first balloon goes in, and everybody has to hold their nerve a bit. And it's certainly better than putting the tube back in or putting another tube unless you downsize, because there is a shearing trauma effect. But I really like using the balloon if I can get away with it right that first time, then see what I've got. That tells me more likely where the problems are, and then I just a bit more clear in my mind about what I'm gonna take.
Yeah, I mean, we will come on to balloons in a bit. I must say I'm not quite as in love with balloons as I was a few years ago when they came out. I found that certain situations they're absolutely fantastic, but when there's a big boggy mass of tissue, you squash it and then it reappears 10 minutes later. Sometimes rather worse than it was the first time, but we'll come on to that. This is just a picture of another lovely subglottic cyst. This is one I did, this is, I'd bitten the roof off it with the 2.9 microdebrider, and that's the lovely sort of neat job you can do, so that you can see a lovely big cyst cavity and almost no other mucosal trauma. So that's why I like the microdebrider. Clearly, that's the best result I've had. I'm not showing you the bad ones, but it doesn't really matter. Right, here's a good one. Another case of Julian's. So we've got a 5-year-old boy who unfortunately had a very large astrocytoma and a big neurosurgical operation, was then intubated for several days afterwards. In the 2-3 weeks post-op, he developed progressively worsening stridor. So Julian elected to take him to theatre. Steve, would you like to take us through what the appearances are here?
So we are seeing a bit of cord mobility, which is good. He's obviously had neurological intervention.
Yeah.
And we have clearly an evolving subglottic stenosis, don't we? Which is looking like it's a grade 3. It's fairly significant, isn't it?
Yeah.
We're going through it. It looks like it's something you might be able to do something about, because it's a thin band, isn't it? And then you get into what's looking like a normal trachea. So in actual fact, whilst this is quite a severe stenosis in some ways, if the history is quite acute, this is something that could potentially do quite well.
Yeah. So what would you do in Newcastle? So you're sitting there in theatre with the suspension, and the child's anaesthetised, and the anaesthetist looking at you, anxious to get off to go on his bike ride.
Yeah. So I would balloon this, but I'd start with. So I don't always, if it's more circumferential edematous type things, I don't always make incisions, but I would make cold steel incisions, Mercedes Benz style, so anterior and then 2 lateral incisions,
Okay.
and then balloon that, and I think it'd do really well.
How do you choose the size
Initially.
of balloon, Steve?
I look at a sizing chart and just work it out for the age, and it's about 1 millimeter more than you'd expect the cricoid.
Yeah. And what sort of pressure do you blow it up to?
Yeah, well, just whatever it says. So they all have a rated pressure, and the rated pressure basically tells you what size the balloon goes to. So as long as you haven't picked a crazy size, you're going to get it to that size. So if you go to a rated pressure lower than that, then you might not actually achieve the size that you think. And so I go to the rated pressure and 2 inflations of 60 seconds.
Okay, great. For 60 seconds times 2.
Times 2.
Yeah, that seems to be roughly what most people do. Is there anybody, Hannah or Ravi, are you both looking at that itching with your finger on the trigger, ready to get the balloon out as well?
Yep, that would have been what I would have done too. Yeah. But we do 2 minutes. We're really aggressive with our balloons, so 2 minutes twice.
And I'll split the difference. So I go 90 seconds, and certainly that's what Mike Rutter, who did some cadaveric studies on this, decided that was an optimum length of time to break the fibers. And
what did you say, 90 seconds?
He said 90 seconds seemed to be the point at which you crossed the tipping point, so you didn't get contracture. I think if I went to 2 minutes, my anesthetist might pass out. So I think, and certainly between 60 and 90 seconds, you do need to keep an eye on the color of your anesthetist. But and I don't. And in terms, I do like to make cuts as well. I don't tend to necessarily make them Mercedes-Benz style. I think that as you go through the stenosis, you get a sense for, they're often not even, you get a sense for where cuts are going to be have a biggest effect. So whether it's 1 or 2 or 3, you get a sense for the thin bit and the bit that's most in the airway. And then you kind of have to conceptualize in your mind's eye, if I cut there and then stick a balloon in the middle of this, where am I going to get my results? So yeah, I think the balloons really transform these particular stenoses.
Absolutely. And of course, Julian did exactly that. He got the balloon in there, and that's a typical, that's after one sort of 60-second go. And you did 2 on that, and I think
I did 3. So I tend to do 60 seconds 3 times. I think often it's governed by when they start to desat, to be honest. So, you know, but yeah, I tend to, I don't, yeah, I didn't know about Mike Rutter's cadaveric ones, but yeah, I just picked 60 seconds. It seems a good number.
Has anybody on the panel seen or heard of anybody blowing up the larynx or trachea with a balloon? Oh, tearing it, basically, is what I'm saying. Anybody?
I've heard people tell me it's happened, but I've never personally been involved or had a close contact with that.
All stories in the pub sort of thing. Yeah, I mean, I don't know if anybody has. I mean, I think Mike Rutter and some of the Cincinnati group did try with animal studies in the lab, and they found it was remarkably difficult to actually tear the trachea, provided there's not. Mike
Rutter's got an interesting video. There's a bronchial perforation, isn't there? So when they're blowing the bronchi down the lower airway, which just heals over time. The only other thing I've seen actually was a bit of somebody was using a balloon and actually caught one of the cords. So you know, it's this sort of sharper bit of the balloon and traumatized the cord. And there's actually a bit of cord loss and a bit of notching.
And certainly, the bronchus. So if you're in the bronchus and you're using balloons, it's a different ball game. There's loads of case reports of people transecting the bronchus. But yeah, in the subglottis, I think you're really safe, and upper trachea. But as you say, you do have to be careful, particularly second time round. The point of the balloon often not quite as straight as it was, and you've got to be a bit more careful as you navigate it through the glottis, because you can certainly traumatize the cord. I think the other thing that the Cincinnati people talk a lot about is this idea of melon seeding, where if there is some, if the patient is still breathing, you get the sense the balloon is pulling away from you. And they've seen this where the pressure has actually damaged the exit channel of the balloon, and they've not been able to deflate the balloon. So it's just something, and certainly if you've got a patient breathing against a balloon, that's probably not a great situation anyway, because of course you can precipitate pulmonary edema, so it's often better just to deflate the balloon, get them a bit more apneic.
So let's go for the 4-week post-dilatation video. This is a follow-up. Let's see if this is going to run rather slowly. And you can see that, as was mentioned before, you don't mend them completely by doing this. You know, there's always a little bit of stenosis remaining, and sometimes it comes back, and sometimes it needs another go once or twice. Julian, do you remember if you needed to do this again, or were they asymptomatic?
I think I ballooned them twice, and then that was it after that.
Okay, there we go. That's so 2 balloons, 4 weeks post dilatation. Okay, and that's 12 weeks down the line. So still what I suppose you'd probably call that a grade 1-ish, and I think that's where you parked it. Wasn't it?
He was pretty asymptomatic. So the danger if you keep ballooning is that you can sometimes just make things worse. And so it's just trying to get that right balance between not sort of traumatizing things too much. And so I decided not to balloon him after the second ballooning. And I haven't heard anything since. And that was probably about a year ago, maybe 18 months.
Yeah, and he's done really well. Okay, very good. Let's move on a bit. Now, Hannah, I'm aware that you've got to go to work at some stage. Are you okay for time?
Yep, got another half an hour or so. I'm good.
Half an hour, that's great. And Ravi and Steve, I'm aware that you've got to go to bed at some time. Are you okay still? Yeah?
Yeah, all good, yeah.
Okay, in Bristol, obviously, we party all night after we've thrown statues in the canal. Let's try and move on a little bit. This is one I don't necessarily need you to comment on. This is just to say this is an illustration of the fact that it just doesn't always work. It doesn't always go the way you plan. So here's a child with a little bit of intubation trauma the first time round, which was I don't think we actually did anything about it the first time round. The second go isn't running. But he had a balloon dilatation the second go. That's the third go. I'm sorry these videos aren't really running. I think the computer's overwhelmed. But this is a child who's had intubation trauma from being a prem and has had 2 balloon dilatations, but it is getting progressively worse despite balloon dilatation. Anybody had that experience in children before, where rather than making it better, you seem to be making it worse?
I suppose the big question is, are you really making it worse, or is this just the natural history of what's going to happen anyway, and your balloon's just not making it better?
That's a very kind comment, Hannah. Thank you very much. That's not what it felt like at the time, but it is possible, yeah. Do you think there are any patient factors that would predispose a child to this sort of thing? I mean, what do you think about reflux? You know, the standard blame everything thing in ENT is gastroesophageal reflux. Do you think that would possibly cause this? Personally, I doubt it, but I don't know what you think.
I mean, they're all on a PPI, or at least in my hands, they're generally on a PPI, but I agree, I'm not convinced it always makes a lot of difference, but I'd certainly be treating them with a PPI. I think lower airway disease is often a part of it as well. So, you know, chronic infection. Sometimes azithromycin or just tailoring some antibiotics to whatever they're growing in their lower airways can be useful, but I'm usually suspicious there's some inflammatory process going on in their lower airways as well.
Yeah. Okay, Steve, what if you had this scenario where you were serially ballooning what you thought was a stenosis, or what was a stenosis, and it was apparently getting worse? What would you do here?
Yeah, how old's the child?
Let's go back for a minute.
They were probably about 6 months at this
about
sort
6
of time.
months of age, yeah.
Yeah, it's very difficult, isn't it? And I think, try and sort out as much as you can, treat the reflux, optimize medically, and then it's quite a difficult conversation, isn't it? Is there a bit of glottic level involvement there as well as subglottic, or
a little bit actually? But
I think this one had a left vocal cord palsy as well.
Oh, pardon, I didn't tell you that. Yeah.
but the subglottis is just getting worse.
Yeah.
So that picture on the right is the subglottis.
So the child was, you know, was responding very short period after each balloon, getting worse quicker and quicker. So we decided we'd have to intervene, and the only interventions that we could consider would be a tracheostomy or an LTR. So we went for a single stage anterior graft LTR, which I suppose in retrospect you might be surprised to hear didn't really work terribly well. Initially when we pulled the tube out, the graft looked in a very nice place, but then it started narrowing down. There you are, just below the graft at 4 weeks, and it essentially got worse and worse. And I'm sorry these videos aren't working out terribly well, but effectively it wound up with a tracheostomy, and we put a tracheostomy in and sat on it for 2 years, and we've just looked back, and it's now a much more organized stenosis. I'm sorry you can't see the pictures terribly well. It's one of the sort of hard stenoses, which now I imagine might respond to an LTR a bit better. I mean, Ravi, do you think that I would criticize myself here for not predicting the outcome of the LTR. Some people talk about children who are just reactive and they keep scarring and they keep swelling. And if you do an LTR, that's not going to go very well either. Do you think that's a reasonable point? Should I have just gone for the trachea?
So when you say LTR, I presume you're talking about a thyroid allograft, or did you use costal cartilage?
So I do an anterior cricoid split, re-intubate with an age-appropriate tube, and put a bit of costal cartilage in.
Oh, okay, fine.
Yeah,
I think. Well, I have to say, in that age group, I would have generally done an endoscopic cricoid split, just because it's so much quicker, and in that age group, I tend to tends to be my go-to. I know it's going to fail, and then you go to a trachea. So that in my eyes, I think that's probably where I would have gone to, even though he's not, he was 6 months old.
By this stage, he's I think he's still under a year, but he's sort of about 9 months by the time he did the LTR, I think. Yeah,
I've just always not really gone for costal cartilage in that age group. I've typically done an endoscopic split. I've sometimes done an open split with a thyroid allograft and then moved to tracheostomy. Those have all failed. So that's probably what I would have done. But you just roll the dice, isn't it? I think it's always worth a shot, isn't it? And I think you having a trachea for a couple of years isn't necessarily huge fun. So I think it's definitely worth a shot.
Steve, would you have, say he'd been serially failing these balloon dilatations, would you have done something like an LTR or a...
Yeah, well, I think you just have to counsel the parents, don't you? Which I'm sure you did, which is present them with those options, which is, the tracheostomy, would work as a tracheostomy, but it's a huge burden on the family and comes with the consequences. Plus, one of the things about the tracheostomy is you then leave evolving disease above it. So, it sounds like the stenosis hasn't worsened horribly here, but you could get horribly worsening stenosis that needs more attention. Yeah. So there are, there's downsides to a tracheostomy. So, and then the family have to then balance that out. An operation that might not work, and with it being a left cord palsy, quite reactive larynx. I guess it's one that hasn't had a great outcome. But I think if ever a lot of families would have been in that position with that discussion, it would be attractive to try something that could be done, with a degree of safety. I think.
I completely agree. I think they nearly always do that. That you discuss the idea of a tracheostomy with the families, and they do almost anything to avoid one. That's a bit complicated to start with. Hannah, would you have gone for something fairly significant like an LTR?
Look, I think probably in our centre with a under 6 monther who's obviously had a stormy course already has a vocal cord palsy. In retrospect, I'd probably say I'd just go to a trachea. I mean, it's hard to say. Obviously, you're guided by your family as well, but a trachea's safe. You can get them out of hospital. Yes, it's not ideal, is it, for the family at home, but you've got a safe airway while you wait for everything for the child to grow. So I think I probably would have gone trachea, but I could have been pushed the other way as well for exactly the same reasons that you're talking about.
Okay, that's fine. Just before we go any further, we have a question typed in from a Mr. Quo of Birmingham, who asks if anybody is using cutting balloons. I mean, I've certainly heard of them. I've seen them with the reps. For people who don't know, these are basically balloons with tiny little blades embedded with them, and they cut through the fibrous tissue. They sort of do the Mercedes-Benz incision for you. Anybody use it? Steve, I mean, you're the real expert on balloons.
Yeah, well, not really.
No, I know, but
I have some data on balloons, but nobody did. So in the prospective UK study of 130 odd balloons, there was nobody used the cutting angio balloons. And I've looked at them, but I would rather do, if I was going to do incisions, a bit like Ravi said, because not being too prescriptive about it, you can actually have a little look and start the incision yourself, because it's almost, you're making a release point. You're trying to control the way the tissue tears is effectively what an incision is. I just think you've got more control of that if you do it in 2 stages rather than try and do it all in a one, would be my view.
Okay. All right, good. Let's move on. We're still good. This is a really interesting case. So I am not in the hospital, but I get called because the general surgeons have taken a very new baby to theatre because it has an imperfid anus and they want to do something to its colon. And it didn't have any other real visible abnormalities, although you'll be aware that a newborn with an imperfid anus may well have other things, but it had a normal chest X-ray and no cardiac abnormalities as far as they could be certain. No real airway abnormalities preoperatively, but they were unable to intubate with any of the tubes they could find in the anaesthetic room. And urgent call put out for ENT, and I was the unlucky one who was closest to the hospital, so I went in and did an MLB, which may or may not play. I don't think it's going to play, rather sadly. What this shows is basically a congenital anterior subglottic stenosis, and the distal airway was a little bit malasic, but essentially not bad. This stenosis was relatively thin. It wasn't like a membrane. It was, maybe 3 millimeters, but that's what it was. The glottis and the supraglottis were normal. So they obviously had to intubate it or get an airway of some sort to proceed with surgery and post-op care. So, I'm in a slightly difficult position here, because obviously the safe answer is to just get on and do a tracheostomy and worry about that later. But the slightly more racy answer is that you're going to go in and do an acute cricoid split and put in an age-appropriate tube and maybe find some cartilage to go in and see how you go. And of course, it's not a very big operation. People think an LTR is a big operation. It's not really that big an operation to just expose the cricoid and the anterior thyroid cartilage, and then to get a little bit of thyroid ala out there and stitch it in. So who would go for the LTR cricoid split approach, and who would go for the trachea in this scenario? Ravi, you're first.
Yeah, no brainer, endoscopic cricoid split.
Endoscopic, okay. Now my feeling is that was quite thick, and I'm not, yes, it might have done it. Steve?
Yeah, and I think you're right about doing something in the more racy option. I think the more you've done, the more I've done over time, the more I just want to correct the problem straight away. Yeah. But I think it needs to be open, because I think that anterior web is not just a thin web, and I think I find when I've done these that I actually end up taking out a bit of cartilage that forms the anterior, actually almost carve it out to create a new anterior commissure, and a bit of a point, and then put the graft high up within that, and that's the best chance of not getting a blunting and a web, I think.
Yeah, that's good. Hannah?
Well, could you get any tube through it? Could you get a 2.5 through it, or two, or anything through it at all?
They may have got a 2 through it. One of those things that look like a feeding tube.
Yeah.
Barely ventilate through, and the first molecule of phlegm comes along, and the thing gets blocked up.
Yeah.
Not a proper airway.
Yeah. I would agree that the cricoid is going to be very abnormal in this child. It's going to be very thickened there. maybe less is more at the beginning. Maybe it's reasonable to do a endoscopic split and intubate it and see what kind of result you get out of that. It's quicker, isn't it, potentially? And then have a chat to the family. But it's interesting, the child's been doing well up until now. It's hasn't had any airway problems. And I certainly have some, very significant webs who are completely asymptomatic, and you can only get a 2.5 tube through them and try not to do anything to them for as long as possible. So
well, it was pretty clear that we were going to have to do something. Yeah. So anyway, I was obviously in a good mood that day, feeling up for a bit of action. So I did a single stage open procedure. So and it was really straightforward. I exposed the anterior thyroid cartilage and cricoid trachea, made a slit. We put an age-appropriate tube in, which I think was a 3.5, that went in reasonably easily, and then I filled it in with a bit of thyroid ALA, stitched it in and left it intubated for 7 days. I mean, the thing would have probably been intubated overnight anyway, so I didn't feel it was too bad. And I'm very pleased to say that it actually, you're not going to be able to see the awesome majesty of the graft that I got in there, but it looked like Michelangelo had painted it on. It looked so good, which is slightly unusual for Bristol, obviously. And I'm pleased to say the child has subsequently done very well. I think I took it back a few weeks later, and there was a little bit of a mild grade 1, but asymptomatic. Parents were very pleased, and so was I, because sometimes these things work really well and you feel very clever, and sometimes, despite doing a beautiful operation like the previous LTR, they just don't work. Good. So I think I'm probably going to let you all off with that. What do you think, Julian? Do you want to go and talk about HJ?
It's up to you. It's your patient. I think
okay.
It's your patient. Yeah.
Okay. Well. Okay. We. The only problem is even on the big computer, the actual videos have stopped. So I'm probably not going to talk about individual cases anymore. I'm aware that there may be a range of different trainees watching, some of whom are, fellows or senior trainees who know exactly all the long words we're using, some of whom don't. So this is a picture of a cricoid split, and a cricoid split is essentially where you make a vertical incision just below the anterior commissure of the vocal cords, through the anterior arch of the cricoid into the upper two tracheal rings when you have a stenosis. And then you re-intubate it with an age-appropriate tube, quite a decent-sized tube, and you don't do anything else. You just leave it like that, intubated for 7 to 10 days, and the idea is the soft tissue fills in that gap. Dave Albert used to tell me that he felt that it allowed the edema to get out of the intact ring of the cricoid. But you don't put a graft in. Now, some people do a lot of these, and it's generally an operation that is done in very small children. I must say I've not had a great deal of success with these. The first one I tried developed a tracheocutaneous fistula, which I felt really embarrassed about. Ravi, do you do a formal cricoid split like this? I know you talked about the endoscopic one.
Yeah, so I do for failed endoscopics because I think it's such an easy, quick operation. And then if I go to an open, I always use a thyroid ALA graft, which I think, you're there, you don't really have to expose anything, you don't have to get involved with the ribs. So I think, and a thyroid ALA is great. It's incredibly easy to harvest. It can be a bit thin sometimes, and sometimes gets a bit wobbly, but I really like it. If I'm going to do an open split, by and large, I'll put a piece of thyroid ALA in there.
And of course, as soon as you put a graft in, it becomes a single stage LTR. It effectively, doesn't it? It's the same operation, just with a graft. Steve, do you do the old-fashioned open split without a graft?
Yeah, well, the last one I did, and the last one was several years ago, and I was trying to think why it had been so long, and I just think because the balloons and the way we intervene and all these things we were talking about with granulation, it's just, I'm ready to do one, but the cases haven't come, and we're not putting trachees in because we're giving up. We're actually just, we're managing as Julian and you've done to do reasonable jobs and get them through these stormy paths, I think. So I haven't had to resort to this for about 7 years, but the last one I did was open. But yeah, I can see the merits of endoscopic.
It's the balloon that's changed it. I'm sure you're right.
Ravi, are you doing a lot of endoscopic splits? It sounds like you are from the way you talk.
I don't know what a lot is, but in the scenarios we discussed, I think it's a real kind of low risk, high impact, operation. It doesn't always work. You have to have an incredibly sharp sickle knife for it to work. And we use a disposable sickle knife in Sheffield that we got a company to make for us, and they sell it. They call it the Sheffield ACS knife, anterior cricoid split knife, and it's costs a £5. And I think that's why the operation works. You just have to have an unbelievably sharp disposable sickle knife, and if you've got that, I think I really think it's really quick and easy. And so that's my go-to. Obviously, so I do that is my go-to, I think. And then with an open if they fail, and then a trachea if they fail.
Hannah, what's your favourite operation?
I'm not the same as you guys. We just haven't seen a lot of kids needing to go to these kind of operations more recently. I was just thinking about the last time we had a situation like this, and I must say I put a graft in. Probably would have got away with just a cricoid split, to tell you the truth. I'm not sure if what the graft added whatsoever, but it seemed like a fun idea at the time. Endoscopically, we haven't got a lot of experience. Certainly used it posteriorly to put in posterior grafts endoscopically, and we've got a beaver blade works quite nicely, a long-handled beaver blade, and that just cuts through like butter endoscopically, which is beautiful. Just the cases seem to not be occurring as much perhaps as they used to, and the balloons also are better, and we're managing things more endoscopically.
Can I just ask the panel, where do you take your alar cartilage from? Mike, are you able to go back to that slide? Just go up.
Yes, is it?
Do you take a sort of a window out of the alar, or do you take the top part of the alar? Where do you take your cartilage? Where do you harvest your cartilage from?
I can't find the slide.
I think I might have a picture of it.
There we are.
Do you do it like in this photo, or?
This is the Monnier book, isn't it?
Yeah.
Yeah. Does everybody take the thyroid alar from there, or do you take a bit from the middle?
So I take it exactly as it's described in that picture.
Yeah. Excellent. Okay. But now going back to the business about grafts or just open splits, I just think if sometimes if you imagine the cricoid ring wanting to close down again, I think if you stick a graft in there, it kind of holds it open. And I also think that if you can get an almost airtight seal with the cartilage, it reduces the amount of inflammation you get post-op. But there are people who are big fans of the open cricoid split and some people who aren't. So, there isn't necessarily a right answer. And of course, this is the traditional thing where you get a bit of rib cartilage, which is a lovely big piece of rib, which I quite like, and you just suture it in and it holds the cricoid open very well. So that's a single stage LCR. We're not going to go on to any more complicated airway surgery than that because it's we're out of time and it's not really within the scope of the talk. So I'd quite like to make a few announcements before we go. BAPO is still on the 18th of September in Birmingham, unless Stephen or Ravi or Mike can tell me any different. As far as you know, we're still going ahead, aren't we? I think
holding on.
You can all pretend that you're going to test your eyesight by driving up to Birmingham. Clearly, it's perfectly reasonable to do so nowadays. Hannah, do you have COVID in Australia still, or have you kicked it out?
Well, yesterday we had our first day of no community spread COVID. So we had 2 cases in New South Wales, which were brought in by foreigners on planes. They were in quarantine. So I suppose we haven't got a lot at all. So we're kind of in our own little isolation bubble down here, not wanting people to come in and not leaving. So.
Are you working normally, or are you still restricted?
Yeah, apart from social distancing, I mean, that's probably the only thing that's kind of different in that we're doing less because we're having to social distance for clinics and also in the theatre complex. Yeah. But otherwise, normal masks, normal level of PPE, not testing anyone, just asking questions, cancelling if anyone's got temperatures or any kind of COVID-like symptoms. They kind of don't get an operation unless they really need one. But realistically, the chance of us coming across someone is about 1 in 10,000 at present in our community. So we're feeling very privileged down here to be in an almost normal situation, but we are in isolation from the rest of the world and probably will be for quite some time.
Okay. Ravi, you'll be pleased to hear that I tested positive with the antibody test.
Oh, hooray.
fellow survivor, although I was nowhere near as bad as you. Steve, did you have it at all?
Congratulations.
Well, I had some mild symptoms, but my antibody test hasn't been done yet, but I suspect it'll be negative.
Cool. So
I think we can be reassured that Birmingham BAPO is going ahead, because we don't think there's going to be a second wave in Britain, because we've managed to keep the first one going. So that's been our approach.
Driving around, coughing.
Yeah, Michael Crowe said the lecture theatre will hold 300, and we usually get about 120, so everyone can sit. You can have 3 chairs to yourself, so, and there's a big car park, so you can drive and sit socially isolated in the lecture theatre.
And 2 of the council have got antibodies already, so you're pretty safe.
Perfect.
So ESPO has been moved because of the pandemic. ESPO has been now moved to February 2021. Unfortunately, it won't be quite as warm in Marseille at that time of year, but it'll still be great fun. And Liverpool was going to be 2022, but in fact it's now been moved to 2023. Is that right?
Yeah, that's right.
Yeah, so the dates to follow. So fantastic. So that's all I need to say. I'd first of all like to thank Hannah very much for getting up early. It's a fantastic thing. And both Steve and Ravi and Julian. And I did say I was going to take points off everybody if they showboated at all, like people do in meetings. I don't think there was any showboating at all there, was there? I think you all gave nice shoot from the hip answers to most of the questions without too much sort of mincing around. So that's exactly what we want on these webinars. This will be edited down and put on the AOT and the BAPO website. I haven't done the cochlear implant one yet because it needs a little bit of editing. They'll both gone together. In 2 weeks' time, we're going to do another one. It may be a middle ear talk, but we haven't decided yet. We'll try and get a proper program up and running that we can put on the AOT website. Anything else from anybody in the panel? No.
Just thank you so much for the invite to be here. It's been lovely to see you all, and I wish we could all see each other in person, but I think that might be a while yet.
May have to wait till Marseille.
It might be a bit longer than that, Mike, I'm afraid.
Okay. Well, it's nice to see you anyway. Okay, guys, thanks very much. That was really good fun, as always. I'll see you soon.